The UTI Antibiotic Hierarchy 2025 Update. The landscape is shifting. Hello, colleagues, doctors and pharmacists. The management of urinary tract infections is undergoing a significant shift. Between the FDA's 2025 approvals of new agents and recent comparative data, the way we rank oral antibiotics for UTIs has changed. Today, we're looking at the definitive best-to-worst hierarchy based on the latest evidence, including critical data on clinical resolution rates and optimal treatment durations. The gold standard, first-line agents. Let's start with the champions. Nitrofurantoin remains a powerhouse. At 100 milligrams twice daily for 5 days, it offers minimal resistance, less than 9%, and carries a clear recommendation for cystitis duration. Crucially, recent comparative trials, like the one shown here, demonstrate that nitrofurantoin outperforms fosfomycin in clinical resolution. At 28 days, nitrofurantoin achieved a 70% clinical resolution compared to just 58% for fosfomycin. It also had higher bacteriologic success at 74% versus 63%. Plus, we now have clear evidence that it's safe to use in patients with a creatinine clearance as low as 30 milliliters per minute. Next is TMP-SMX. A 3-day course is highly effective, but here's the catch. Check your local antibiogram. If E. coli resistance in your region exceeds 20%, it loses its first-line status. Moving to the 2025 newcomers, pivmecillinam is now FDA approved for a 3-day course, showing comparable efficacy to longer regimens. And keep an eye on gepotidacin, the first-in-class triaza-esenaphthalene. Phase 3 EAGLE trials show it's non-inferior to nitrofurantoin, making it a vital tool against MDR strains. The use with caution second-line agents avatar. Now, let's talk about the fluoroquinolones, ciprofloxacin and levofloxacin. While they are highly effective, we must reserve them to prevent collateral damage and serious adverse effects. According to current guidelines, if you are treating simple cystitis, the duration is just 3 days. However, for pyelonephritis, you're looking at 5 to 7 days. We also have third-generation cephalosporins like cefpodoxime. These are useful step-down options, but remember, PK/PD matters. Cefpodoxime has much better urinary excretion than cefdinir, making it the preferred choice in this class for UTIs. The losing ground, third-line, inferior agents. Finally, the agents we should generally avoid for empiric therapy. Cefdinir, or Omnicef in the USA, is a frequent UTI fail. Why? It has poor oral absorption and only 13 to 23% urinary excretion. Studies show it leads to higher readmission rates. Similarly, amoxicillin clavulanate and first-generation cephalosporins like cephalexin often show lower clinical cure rates than TMP-SMX or fluoroquinolones. If you must use them, Table 4 notes that a 7-day course is recommended for pyelonephritis, but the evidence remains not enough for a clear clinical recommendation in many other syndromes. And as for ampicillin and amoxicillin alone, with resistance rates reaching up to 90%, they essentially have no place in empiric UTI treatment today. Conclusion and key takeaway. The bottom line? Trust the 5-day nitrofurantoin course for efficacy, reserve the fluoroquinolones for when you truly need them, and be wary of the poor urinary penetration of certain beta-lactams. For a deeper dive, check the duration levels of evidence in Table 4 of the latest guidelines. Stay evidence-based, and I'll see you in the next clinical update.